Great to see you again. Welcome to our podcast. And yeah, I'm quite excited about bringing you on to have a proper chat. Do you remember last time we met in Dallas? No, was it Dallas or
I
was it?
do.
No, that was
Is
Baltimore. That was Baltimore, wasn't it? The
Yeah,
last
because
one.
we met originally in Dallas,
Yes,
but then the chat we had was in Baltimore.
that's it. Absolutely. So yeah, we had a brief chat, but today we're gonna have a proper discussion. Yeah, how are you doing?
I'm good.
Yeah,
I'm good. Thanks for asking. How are you doing?
not too bad. Yeah, just busy. Just
Yeah.
as you know, the world of ADHD is never ending. It's never. Yeah, it's
No. No, we don't let it be ending.
yeah, exactly. So, I thought today we can discuss about mental health in teens with ADHD, because that's something that I know you're very
Perfect.
passionate about as well, and I see it clearly in my practice as well. We see lots of youngsters coming through
Yeah.
the door, struggling with their mental health, and there's so many issues out there that goes on that sometimes it's hard to actually get for them to get the right support that they need. In addition to their ADHD, sometimes they're co-occurring.
Absolutely.
Sometimes some of those mental health issues could be explained by their undiagnosed ADHD, which you obviously clearly know as well. So I want us to maybe spend some time talking about that. And also just to get an update in terms of how things are over your side as well. I know you got your own private practice as well. So just to give us a flavor of like, how things are going on in terms of ADHD management in
Yeah.
the States. We've had a shortage of medication. If we have time, I want us to also talk about that, if that's all right with you.
Yes, we can
Yeah.
do that.
Okay.
Yep.
So, for our listeners who are not familiar with yourself, do you mind just giving us an overview of what you do and who you are and where you're based?
Sure. So I'm Dr. Carolyn Lentzsch-Parcells. I'm a board certified pediatrician and I practice what's called adolescent medicine in Fort Worth, Texas. My practice is called Our Place Adolescent and Young Adult Health. And I have ADHD myself. So a lot of my practice is also taking care of ADHD kids and young adults, because needless to say, it's quite near and dear to my heart. And other than that, I do a lot of kind of speaking and educating and just kind of trying to get as much good information out there as possible for folks.
Excellent. So, what was it that drew you to ADHD?
Having it.
Okay. So you were diagnosed
Having it and
first,
being surrounded by people with it. Well,
right?
I joke with people that when you if you open up the DSM-5 criteria, which is the diagnostic manual, right, that we use to diagnose these conditions, I joke that when you open up that book under ADHD, it's just my family tree.
Right.
It's just, yeah. I mean, just about all of my family has it, and we didn't really start to discover it or learn about it until my generation. And actually, my younger sibling was diagnosed, and then as he's being diagnosed, my parents are going, hold on, this sounds familiar. And so I was diagnosed at 17. But then, the rest of the family kind of over the years has been like, oh, yeah, it's not just, it's all of us, isn't it? And so, it very much, I see all the gifts as well as all the challenges that come along with it, not only in myself, but then how it manifests differently in my friends and family. And so from actually a pretty young age, once I understood what it was and how it affected me, it was very clear that this was going to be a very big part of my life and my career.
So what's been your journey since you got the diagnosis? Going into your adult life and obviously to eventually getting into the career that you were in as a
Well,
medical
so
practitioner.
sure, sure. So I was actually I've been pre-med since I popped out of the womb. That I always knew I wanted to do.
Right.
I as my earliest memories of knowing anything about what a career was, I wanted to be a physician. I literally was that kid that was giving physical exams to my dolls and giving them masking tape casts.
Okay.
So that
Yeah.
that was already gonna happen.
Right.
And I always knew I wanted to go into pediatrics because kids are awesome and adults are not as awesome, in my personal opinion. Um, so that was already on the books. And actually, what I originally wanted to do was pediatric hematology and oncology, so kids with cancer. And then really, it was a series of a couple of events. So I was diagnosed in high school and started to kind of understand a little bit more as to why. I always knew I was different. I just didn't know how or why. and started to learn about myself. And then when my very first year in medical school, I had a preceptor who was a pediatrician. And I will never forget this. We were in a room with a kiddo who had ADHD, and he was having a really rough time. And you could tell just by the body image of him and his mom that things were not going well. There was a lot of tension and a lot of stress. And I didn't know that my preceptor had ADHD. We hadn't had that conversation yet. And in that room, he's like, well, you know who else has ADHD? And the kid just kind of looked down and shook his head, and he said, I do. And the kid looked up, and you just saw the look on his face of like, just like, what? This doctor person has ADHD?
Yeah.
And you saw the look on his mom's face. And I was like, I caught it immediately. I said, yeah. And you know who else has ADHD? I said, I do. And just like both of them, like I'm going to get choked up just like talking about it. And I don't even want to tell you how long ago this was. And it hit me very clearly right then and there, the value of my own story and of sharing my own story, and the impact that could have. And so that was kind of one of the inciting events for me. And then going through medical school and going through all my rotations and doing adolescent medicine rotation, I had a mentor who sat me down and said, you know, this is what you're going to do, right? And I was like, no. And she said, yeah. Right. And she was right. Mm-hmm. So it just kind of naturally evolved as I figured out what I was interested in, but also where my gifts were, and where I felt like I could really make the biggest impact. So that by the time I was done with residency, it was a pretty clear path forward.
Yeah, fascinating. And if we talk about, okay, obviously the main topic of discussion for today is about the mental health in teenagers. So if you are able to just provide us with an overview of ADHD in teens and how it impacts on their mental health.
Sure. So, I mean, you could write a whole dissertation on that, right? But I do think, ADHD, so there's actually, I'm going to split it up a little bit because there's undiagnosed ADHD and there's diagnosed ADHD. In undiagnosed ADHD, especially in teenagers, you start to see a lot more secondary depression, anxiety, school failure, relationship failure, social issues, higher risk of suicide and accidents, unfortunately. So there's a lot of really significant impacts, especially for those who are undiagnosed or untreated. For the kids who are diagnosed and treated, you still have higher risk for all of those things. But when they're diagnosed and treated and adequately supported, the risk of each of those things has been shown to go down significantly. The other thing that is really, really interesting to me, and I think this is really important because so many people, it's substance abuse. So many people are concerned that the stimulant medications cause or lead to drug use or abuse. And the data is very, very clear on this. Kids who are diagnosed and treated earlier have a significantly lower risk of drug use or abuse or dependence. Kids who are diagnosed early and not treated have a similar risk to those who are not diagnosed until they're older. When I saw that research, that really hit me hard. That was really fascinating to me. So there's those factors. And I think, living with ADHD in a non-ADHD world is anxiety provoking. And it's stressful. And it's I think especially as we come into our adolescence and trying to figure out who we are in this world and how we fit, that's tough for all teenagers. And that's something that all teenagers go through. But when you feel like you don't belong, or you feel like you can't quite cut it, or you feel like you just can't do some of the more simple things in life that other people can as easily, that creates a lot of self-esteem issues. It creates a lot of shame. And I think the other distinction we have to make is not just between the kids who are diagnosed and treated versus not diagnosed or not treated, but between boys and girls. And to be clear, when I talk about this, I'm going to speak primarily regarding cis male and cis female because we just don't have a lot of data for transgender or non-binary folks. So it's not to exclude those communities. It's just this is what the research we have is, and we need more research on communities that are non-binary or genderqueer or transgender. But for assigned female at birth versus assigned male at birth, the research shows us, and I've seen this in my own clinical experience, that cis girls and women tend to internalize symptoms more than externalize symptoms, right? So we could be hyperactive, but whereas a male of the same age might be overtly hyperactive, visible to other people, our hyperactivity is going to be more in the like tiny fidgets or the little bouncing of the leg, or hyperactivity in the sense of our brains don't stop. Our thoughts don't stop. So we're able to mask it differently and frankly better than males are in general, which is part of why we tend to slip through the cracks more. Girls and women tend to be diagnosed even today later than males do. And inattentive girls in particular get diagnosed later because we don't make problems for nobody but ourselves.
Yeah.
Right?
Yeah.
It's just less obvious. And we oftentimes, and I see this in my clinic all the time, oftentimes the girls are coming into me not for concern of ADHD, but concern for depression or anxiety or eating disorders, which is another thing that we're at higher risk for, or substance use or self-harm or whatever it may be. And it's only through doing a really thorough history. And even sometimes it takes time of trying to treat the depression or anxiety before we go, hold on, there's something else here. And we have to dig deeper. And then we're like, oh, hold on a second. There's something else going on that we need to address.
What do you think about the overlapping symptoms? Obviously, I think that can make it difficult for other practitioners that are not familiar with ADD or inattentive type of the ADHD that you sort of alluded to there, whereby someone could have anxiety and also have inattention symptoms or have depression, and which is why, as a physician or clinician, some, if they haven't been experienced in working in the field of ADHD, they wouldn't necessarily think about ADD or ADHD in that case, wouldn't they? They might be thinking of a mood disorder or anxiety or...
Right. Exactly.
All of that.
Exactly.
Yeah.
Yeah. And you know, the way I describe it to my patients is I tell them, look, here's the challenge. Anxiety can cause difficulty with focus, difficulty with attention. It can even cause somebody to be kind of fidgety, right? And moving around in their seat. It can cause them to have a lot of symptoms that look like ADHD. Same with depression. Depression can cause difficulty with concentration and focus and overall cognitive functioning. It can cause difficulty with motivation, which can cause difficulty with getting work done. So all of those things, so depression and anxiety can look like ADHD. But then on the other hand, ADHD that's untreated or suboptimally treated or undiagnosed can lead to depression and anxiety for exactly all the reasons I just mentioned. And oftentimes too, they run together. You know, sometimes they run together because, again, just the effects of having ADHD, but also there looks to be some genetic components where anxiety in particular runs very strongly in families along with anxiety. So there's also likely a neurochemical genetic component there. And sometimes it's hard to tell. Sometimes it is really genuinely hard to tell what the primary diagnosis is, or do we have one or more of these diagnoses going on? And I think oftentimes the anxiety or the depression is just the more obvious. And I do think sometimes with a really good history, we can figure out the ADHD is there. But truly, there's times where we just don't know until we treat what seems to be the biggest difficulty. So for example, if I have a patient with anxiety and I'm like, dude, I know you have anxiety. That's clear. The question is it just anxiety? Or is it anxiety and ADHD, but I can't tell right now? Okay, well then we're going to treat the anxiety. We're going to see how that goes. We're going to get them in therapy. We're going to do all of the things and reassess. And sometimes when we treat the anxiety, now you see the ADHD more. Or if we're having trouble thoroughly treating the anxiety, sometimes that's because there's ADHD underneath. And if we don't treat the ADHD, we're not going to get the anxiety fully under control. Right?
Yeah.
but it's very nuanced, and you're absolutely, it is part of why it can be really difficult for people to find the care that they need and obtain the correct diagnosis, because it can be challenging.
I'm just thinking at the point of the patient coming in for the first time, presenting with certain symptoms. Isn't that the chance that we can then screen for all sorts of conditions at that stage, rather than presenting? Okay, you're
Yes.
presenting with anxiety symptoms, but let's just throw in a depression screening scale. Let's just throw in an ADHD scale at the same time. You can pick up a lot on that initial presentation
Yep.
when they come in for the first time.
Yep.
Yeah,
I agree. I screen literally every patient that walks through my door for depression, anxiety, and ADHD.
yeah,
I have 3 screeners.
yeah,
They hate me because they have so much paperwork to fill out. But we have 3 screeners, and actually you're going to love this. So it's the PHQ-9 is the first one,
yeah,
the GAD-7 is the second one, and then the ASRS is the next one. Because it's really just the best option we have for our older kids. We use the Vanderbilt, of course, for our younger kiddos. But something my patients had to point out to me, I had a couple of patients that they came to me for other things, not ADHD, pretty intense mental health issues. So we were managing those. And it wasn't until we kind of got through those and they were in a better place that they started reporting, like we started kind of uncovering some of the ADHD. And I was like, how did we not catch this sooner? And I went and looked back at their forms, because I can track them right in our charts. And their ADHD forms were not rating as consistent with ADHD previously. When I talked to them about this, though, it wasn't because they were not having the symptoms. They were underrating their symptoms for 2 big reasons. One, and if this is not the most ADHD thing, I don't know what is. By the time they got to the ADHD form, which is the last form, they were bored and exhausted and done. And so they'd go the minimal line, and they just draw a line all the way down.
yeah,
I'm like, how did I not think of this?
yeah,
Right. And then the other thing that they would tell me is that they would underrate their symptoms because they didn't want to have one more thing, because they'd already been diagnosed with an eating disorder or depression or anxiety or multiple diagnoses. And they just couldn't wrap their heads around being diagnosed with one more thing.
yeah.
So they underrated their symptoms. And I'm like it was heartbreaking, but it was also, I so appreciated that insight and that level of insight, because it helped me to adjust my practice to help people understand that it's not just one more thing. It's just your brain. We just don't have all the words to describe your personal brain.
Yeah.
So we're putting these words together to try to help us understand your brain and how to best help you and support you. Right. But that's part of why I love working with teenagers and young adults, because they'll tell you like it is.
Yeah.
And they teach me on a regular basis,
Yeah. Yeah. The misconceptions around mental health is still out there. We have to bear that in mind as well, as much as, we say we try to raise awareness and all of that, which it's refreshing to see when you go on social media now, people talking about ADHD, you go on TikTok and there's all these videos. To some degree, it's helping. It's breaking some of these barriers and stigmas and all of that. But
right.
In young people, amongst young people, certainly, and I see it, it's kind of still there. Like, you have mental health issues. It's still, it's still a taboo, and they don't want to, speak openly about it. And, some of them are still struggling. You mentioned about self-medicating earlier, and that was, like when they start to, you misuse substances or do all sorts of things.
Yeah.
In some of these externalizing behaviors, getting into fights or, road traffic accidents and all of that, purely because of their misdiagnosed ADHD. And you can see the trajectory which can happen from teens. And the point about what you were saying about the internalizing symptoms that females present with, would you say some of these can then lead into some of the mental health issues that we're describing? If you feel that you have to conform and you have to mask your traits in the school environment, for example, later on down the line, do you see the impact that can have on that teen or even an adult?
Oh, absolutely.
Yeah.
I mean, I can speak to that not just professionally, but personally. I was a very high achieving kid, and I went to a private all girls school, and I'm now a physician and a mom and a business owner. And that all sounds great, but there's a certain level of expectation, and there's a level of expectation on the things we should be able to do. I joke that we should on ourselves. Um,
Yeah.
you know, I'm all these things, right? So I should be able to find my keys in the morning. I should be able to get my kids to school on time. I should be able to find my shoes after trying to get my kids to find their shoes for 30 minutes, right? I should be able to do all of these things that are expected of an adult, a neurotypical adult, a woman in particular. There's a lot of shame surrounding it. The way I tell people is I'm not ashamed to have ADHD. I have never felt ashamed to have ADHD. I feel very lucky about that because I come from a family that talks about mental health, supports mental health, like gets it. But that doesn't mean I haven't felt shame about the things that I struggle with because of my ADHD, right? And that doesn't mean that I haven't felt judged by others because of the things that I do or the ways that I behave because of my ADHD. Like I said, I knew I was different from a very young age. And sometimes that was met very positively, and sometimes it was met very negatively. And, we tend to be very big feeling people. We feel very intensely, which I think is one of our gifts. I know people don't like to think about it as a superpower, but I like to think about it that way. So I'm going to say it. But it's absolutely also one of our challenges because you put big emotions together with impulse control issues,
Yeah.
and you have emotional dysregulation.
Yeah. Yeah.
Right. And so, I think there's all those personal experiences that we have growing up and into adolescence that absolutely serve to form who we are as adults in both positive and negative ways. There's research, and I'm blanking on the exact number, so I don't want to misquote something, but there's research that's been done to show just how many negative messages ADHD children get by the age of 12 versus neurotypical children. And I wish I had it on me because it's shocking just how much more negative messaging ADHD kids get from adults at school and at home by the age of 12 versus neurotypical kids. And I am also a mother, and I will tell you, it's hard not to do that.
Yeah.
It's hard not to do that because we still have to manage our behavior, and we still have to correct our behavior, and we still have to, learn how to live in this world. And it's very hard to avoid that. It's another argument for treatment. It's another argument for support. It's another argument for having people around you who understand it. But those things last. And again, it can last in a negative way as well as in a positive way, right? For me, it's become my career, and it's become my passion, and it's enabled me to help other people. That doesn't mean I don't still deal with some of the baggage, if you will, of growing up as a hyperactive girl in the 80s and 90s, when it wasn't totally understood. Well, we still don't totally understand it, but when it wasn't as well known and understood.
Yeah, no, I agree. I think societal pressure certainly doesn't help. Certainly, you mentioned about females, parents, even anyone, adults, males as well, where you are expected to be the one who's able to get the kids to school on time. You are expected to remember this and to not to lose your keys, to turn up on time, to do this, to do that, and I remember when you mentioned about the negativity. I remember you mentioned that at the conference, didn't you? And I was like gobsmacked when I heard it, and I was like, and I stopped and paused, and I was like, that is actually true. When people view ADHD, I suppose it's the inconsistency, which me and you may have discussed a lot of the times, which sometimes causes the frustration, isn't it? Where teachers, parents can
Yes.
say, you did this yesterday. Why, for God's sake? Exactly, it's that.
Yes.
Yeah.
Yes. And I literally was just having a conversation with a family member about this.
Yeah.
And I was like, yes, it is frustrating to everybody else. What everybody else doesn't understand is that it's even more frustrating to us. We know we're inconsistent. We're aware. We know we struggle to do the things we know to do. And that causes a lot of frustration for us. And it's, I think it's part of why, at least it's part of why we get defensive sometimes. Even when people are trying to help, because, to quote Dr. Russell Barkley, ADHD is not a disorder of knowing what to do. It's a disorder of doing what we know. I love that quote. It hits hard.
Yeah.
And yeah, no, it's the inconsistency is, I think, definitely one of the biggest challenges, not only like for us internally, but then for others. And for others to also be able to understand and accept ADHD and what it is, because there is still, you mentioned stigma earlier, and we've come leaps and bounds for sure. There's been a lot of progress made. We still have work to do. And I still run into adults, teachers, parents, other medical providers, mental health providers who don't, believe it or not, I still run into people who say they don't believe it exists, which is its own issue.
Yeah.
But even the people who recognize it, there's still such a lack of complete understanding. And to be fair, we're still learning about it. This field has evolved so much just in the, decade plus that I've been doing it. I don't even want to say how many years it's been because it'll make me feel old. But our understanding keeps evolving, right? We now know so much more about emotional dysregulation being a part of ADHD for some people, about rejection sensitivity being a part of it for some people, So we are still learning, but there's just, the education is a little bit lagging behind.
Yeah.
More so than I'd like. We're working on it.
That is
We're
true.
working on it.
Which is what we're here. That's why we're doing this podcast, is to help educate people and break down the, what the misconceptions of what people view ADHD as, the typical 3 symptoms: bouncing around, running around, climbing on trees. It's more than just that, which, some people just treat it as it is. The term itself, ADHD, doesn't help, which is misleading. We know.
No. Yeah. No, it does not.
Yeah.
No, it does not. Yeah.
Yeah.
It's very misleading. And I tell people that all the time, the attention deficit hyperactivity disorder. Well, first of all, not everybody has hyperactivity. So fun that we lumped all of that together.
Yeah.
But then I also tell people it's not a lack of attention. It's a lack of self-regulation. It's a difficulty with self-regulation. And in fact, when it comes to attention, it's not that we can't pay attention to anything. It's that we notice everything. We tend to not filter out extraneous stimuli. So like, the bird chirping out the window, the AC, the noise of the AC or the ticking clock, holy crow, enough to drive me up the wall. Somebody clicking a pin, a lot of visual stimuli, whatever it may be for that person. We don't filter that stuff out like other people do. So it catches our attention and it splits our attention and takes us away from the thing we're supposed to be focusing on, unless we're hyper focused, and then good luck getting us to notice anything else.
Exactly. Yeah. Yeah.
Which again is, I think, one of the things that's so confusing to people. One of my other favorite analogies that I learned actually from an ADHD coach who I love, but we are not dimmer switch people. We're flip switch people. We are on or we are off. There is no in between. And that goes for everything. It goes for our attention, our focus, our emotional regulation, our motivation, our energy levels. And when you start thinking about it like that and going, okay, so that means 1 minute we're bouncing off the wall. Well, not all of us, but some of us are bouncing off the walls. But then the next minute we can't even figure out how to get ourselves off the sofa. right?
Yeah.
One minute we're hyper focused, and the next minute we can't even get started on a task. One minute we are reacting more to something than seems reasonable. And the next minute we're not responding enough, right? Or in a way that other people think would be sufficient from an emotional standpoint. And yeah, it's tough.
Yeah, flipping that switch. Yeah, I remember you said that
Yep.
before, and I agree. Yeah, and I see it. Going back to mental health comorbidities, let's think about bipolar, for example, like the rapid mood swings, the ups and downs. You mentioned emotional dysregulation there. For anyone listening, and I've heard some people like kind of going, is it bipolar? Is it ADHD? Is it impulsivity? What's the difference there for anyone listening who might be curious to think, okay, I've got this patient, they have all these kind of mood
Sure.
swings, and what's going on here? Is it ADHD or is it their bipolar? And they're trying to kind of see what help they can give the patient.
Right. So, I mean, I think one of the big things to remember is that bipolar disorder, or at least classic bipolar disorder, is not rapidly shifting. So you're talking about discrete periods of time, days, typically. Everybody's different, but typically, of being manic or being in the middle or being depressed. It's not an hour to hour, day to day cycling, typically. I always say typically because I've been doing medicine long enough to know that most of my patients didn't read the textbook, but according to the textbook. Whereas with ADHD, the emotional dysregulation is much more of a rapid change, right? We can, within one day, I live in Texas, right? We joke about the fact that we don't have 4 seasons, except we can't have 4 seasons all in one day. Kind of like that.
Yeah.
We can go from being in the best mood ever to something happens and we shift, and now we're angry, and now we're sad, but now we're back to being happy, which can be very confusing for the people around us. And so it's a bit of a more rapid cycle situation. The other thing is there's very specific criteria for bipolar disorder and very specific criteria for mania. And yes, some of those symptoms cross over or seem very similar to hyperactivity or impulsivity or those kinds of things. But again, you're talking about the difference between discrete periods of time of having behavior that is not typical for the person versus this being an everyday up and down variable situation with ADHD. Now, by the way, though, to complicate things even more, you can have both.
Yeah.
Right? You can have both ADHD and bipolar disorder.
Yeah.
And, whereas ADHD is typically present from birth, whether, but it may not reveal itself, it may not be obvious until somebody gets into school age years or even older. Bipolar tends to not reveal itself until late adolescence, early adulthood. So that can be the other thing that can be really challenging is you can diagnose someone correctly with ADHD and you can be trucking along with their ADHD treatment. And then all of a sudden we have a change in behavior that we need to reassess. And is it just ADHD? Is it just need for med change? Is it hormonal fluctuations? Or are we actually looking at an additional diagnosis? But I think the real key is the term bipolar gets thrown around in the vernacular, like in the public on social media a lot, without it actually being used properly based on the actual defined criteria of it.
Yeah.
So
yeah,
that's what I would say about that.
Again, we see a lot of teens going back to the teenagers as well. Let's think about self-harm, suicide. That's something that sadly occurs in some of our teens. Some of them might also have ADHD, which is diagnosed. Some of it, in some cases, is undiagnosed. So, what in your practice, in terms of like supporting these youngsters who present with self harm, is it more of a cry for help from what you notice of them, or is it more of a release, or an outlet that they feel, or it's like I don't know. What is it that you notice in your practice with your teens?
So that's a really, really great question. So first of all, 90% of our patients, 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 90 you said this, but I just want to make sure the audience hears this. There's a difference between suicidal gesture, suicide attempt, that kind of action and behavior, and what we call non-suicidal self-harm. So non-suicidal self-harm are things like cutting without intention of suicide or without suicidality. Okay. And they are very different, and they have very different, and they have, I shouldn't say different risk factors, but they carry with them different risks, right? So to the point of self-harm, so the non-suicidal self-harm. So I will actually, if you talk to patients, not just look at the research, but talk to patients, it depends on the patient, why they do it, at least why they verbalize they do it. And I've had patients tell me that they feel numb or blunted out or apathetic, and it helps them to feel something. I've had patients tell me it's punishment to themselves. That one, of course, really breaks my heart. Not that they don't all break my heart, but I've had patients tell me that it helps release anxiety for them. I've had patients tell me that for whatever reason, just briefly, they feel better. And what's really interesting about that is some of the research on this shows that for some people, not all people, which is why not everybody does this, it actually causes a release of certain neurotransmitters like dopamine that, can actually temporarily make their brain feel better. Now, obviously, this is not a healthy solution or a long-term solution, but explains why they get that positive feedback neurochemically and psychologically that brings them back to doing it again. And it's like an addictive behavior in that sense. And it lights up similar parts of the brain. And what's really interesting to me, and it makes sense to me at least, why kids with ADHD are at higher risk for this. Certainly you have the higher risk for depression and anxiety and those kinds of things. And then the impulse control issues. So like when they have the thought of doing it, they're more likely to do it. But what do the ADHD medicines do? The stimulant medications help us by increasing available dopamine in our brains. So when these kids find other behaviors that increase dopamine in their brain, like cutting, like binging, like purging, even though logically and rationally they know this is not a good idea and this is not a positive coping strategy, their brain goes, oh, that worked. I liked that. Do it again. Mm. And the next thing you know, we've got a pattern of maladaptive behavior trying to manage what's going on. And I tell people all the time, whether you're talking about self-harm or eating disorder behaviors or any of these kinds of things, the behavior is not the actual problem. The behavior is the maladaptive solution to an underlying problem. And if we want to deal with the behavior, we have to figure out what the underlying problem is that they're trying to solve and help them develop a better solution.
Yeah.
Right?
Yeah.
And yeah, so it's just, it's interesting, yes, on a psychological level, but it's really interesting on a neurochemical and neurobiological level, kind of where these things connect. And I think that really helps us to then, like I said, then figure out what is the underlying issue. Why are they really seeking this behavior or continuing to do this behavior, so we can actually help them genuinely stop the behavior?
Yeah, which leads me nicely to what are some of the strategies that the teenagers can use to build resilience and self-confidence?
Yes.
Yeah.
So first of all, you said the R word, resilience.
Yeah.
Resilience. For ages in the world of adolescent medicine, most of our research was on risk factors. And then we started going, hold on, but then why does this kid with these risk factors and this kid with the same risk factors have different outcomes?
True.
So we finally started doing research little ages ago on resilience. And there's a lot of really interesting stuff that's come out on that. And actually, one of my favorite books on resilience is a book called Building Resilience in Children and Teens. Wonderful, wonderful book. And it talks about the 7 C's of resilience. And just a few of those, don't want to bore you with everything, but one of the most important ones is connection. And that's one of the things we're really struggling with in our society right now. And it's also one of the things that kids with ADHD can struggle in particular with. Social cues, connecting with people, feeling like they genuinely connect with someone, finding their group, their tribe, their family, their people, their community, whatever word you want to use. And connectedness is such a protective factor for so many things. There's research showing it's protective for addiction as well, right? It's protective for suicidality. It's protective for self-harm. It's protective for depression, anxiety, all of these things. So connectedness is a huge thing. And connectedness, this is where I really, there's the social media is a double-edged sword. Because on the one hand, you can find an amazing community online, right? You can find amazing resources online, and that can be really helpful and really therapeutic with people. But our brains don't respond the same to even seeing someone on screen as we do to actually seeing someone in person, making actual genuine eye contact. Our brain doesn't get the same stuff, right? And so many times now we're sitting here, even when we're with each other, we're on our phones.
Yeah.
Right. And that's hard for that goes for everybody, not just ADHD folks, but as ADHD folks with impulse control issues who need our little hits of dopamine, it is harder for us to get off the screens. But it's so critical to have that real genuine connection with people. The other thing that comes into play for resilience in general, and I think this really can be one of the things that affects us, is confidence, but real confidence. Not confidence because people are like, just giving you empty compliments, but confidence that comes from competence. So the kind of confidence you have when you know you can do something, you're good at something, right? That genuine confidence that comes from competence. And I think that's one of the areas too, where oftentimes as ADHD people, I mean, anybody can have imposter syndrome, but good Lord, do we get imposter syndrome, right? And that difficulty with confidence because we're not sure of our competence, I think can be a real challenge with us, but that can be so protective. And then one of the other ones that I always bring up to people that I think is one of the most important C's is contribution. When we do things for others, when we do things to help others, we feel good. And when we do things to contribute, we then feel competent and then feel confident in addition to building connection, right?
Yeah.
So that is why I do what I do. And that is why I'm got so involved with the ADHD conference, the international conference, because when I go to that conference, that's 3 of the most soul affirming days of my entire year because I get to do all of those things, right? And it just feeds me and lifts me up so that when I do go back into the neurotypical world, I've got that, I don't want to call it armor because it makes it sound like I'm shutting myself off, but I have that, I revive my resilience.
Yeah.
Right. So that I can handle more when I go back out into the world.
There's a sense of acceptance as well when you go to those places, those conferences, isn't it? It's like everyone.
It's so great, isn't it?
You could just be
like,
yourself.
I'm sorry, I know I'm like giving a plug for the conference, but like, I mean, because that's where we met. I mean, it's just so great to be there with like 1,500 neuro sparkly fabulous humans.
Exactly. And you're not masking, you could just be yourself. And it's
that was really one of the first places, if not the first place, where I could genuinely, completely, and totally unmask and still be valued as the professional that I was. I mean, I could go swing dancing down the hallway with Brendan Mahan from ADHD Essentials. And not only did nobody think that was weird, but it gave me street cred.
Yeah, exactly. And you could
turn out. You know what I mean? Like
you could turn out to the party as well, dressed up in your outfit. Do you remember? All of that. Exactly. Just be yourself. Be who you are.
I know. I'm like, I'll be shopping and I'll find an outfit and go, oh, that's coming with me to the conference. We're wearing the sequin blazer to the conference. That needs to happen. Right.
Yep. With the Elton John
but
glasses
no, I think
as well.
Yes. Oh, gotta have the Elton John and the feather boa.
Oh, cool. You can't
Gotta
forget
have the
that.
feather
You
boa.
can't forget that. Yep.
But no, I think it's a concentrated example though of all the things that roll into developing resilience. And I think it's something, one of the things that I see a lot in our young people, and I don't want this to come across as like, oh, wah, Gen Z, blah, blah, blah. No, they're an amazing generation, actually. They give me hope. They genuinely do.
Yeah.
But they've been through a lot. It's not like these kids haven't been through stuff. They've been through a lot, but somehow we're still not building resilience the way we really need to help them get through all the rest of the stuff that they're going to go through in life, because it ain't over.
I mean, we had the pandemic, didn't we, as well? We had lockdown and all of that. We talk a lot about the lost generation. It feels like people just forgot about that, but the aftermath of that, and certainly some of these teens who went through it, little on exams, social isolation, the mental health issues that they had to navigate. Some of the impact they're still feeling it up until now. Some of these, some young youngsters, the young adults now.
Absolutely. And it's, there's something to be said about going through something and getting through the other end, and that in and of itself building some resilience, because you realize you can go through hard things.
Yeah.
And I do think there's some of that occurred, but they ended up about 2 years behind in their social and emotional development, and also for some of them in academics. And so then how does that affect your competence and your connectedness and your confidence? And, all these C's that we're talking about, needless to say, it's not going to affect it in a good way. And I think that's, I do see folks coming out of that now. I do see teenagers and young people catching up on those skills, which I think is also reassuring. But it's been a rough few years.
Yeah.
It's been a rough few years, and it's had its toll on everybody, but I think it's particularly had its toll on our young people.
What advice would you give to parents, educators, teens themselves about, mental health and ADHD?
Oh.
Yeah.
That's a whole 8-hour workshop, isn't it?
If you could sum it up for us.
You're right. No, honestly, I think, again, educating yourself. Right? If you don't have ADHD yourself, learning. Sorry about that.
That's all right.
Jenny. That's my puppy. She was being so good right up until then. So I think educating yourself, trying to understand it as best you can, right? We know we can never fully understand somebody else's journey, but we can certainly try. And I think the more you understand ADHD, the more you understand how our brains work and why we do what we do, and you can then reframe these behaviors. I think that's one of the most critical things as a teacher and a parent. So for example, one of my pet peeve phrases is oppositional defiant or oppositional defiant disorder. I want that stricken from the DSM-5. I don't want humans to ever use that word. Why? Because when you have a child who has oppositional behaviors or defiant behaviors, and you say the term, you say those words, and you describe the child in that way, I don't care how good you are, I don't care how empathetic you are, you immediately have a negative response. You immediately have a negative view of this child. You think, oh, they're doing it on purpose, they're manipulating, or they're doing whatever, right? And then our behavior towards that child is going to reflect that internal negativity about those behaviors. And that child will start to internalize that as, oh, well, this is who I am. They're telling me this is who I am. So this is just who I'm going to be. So why would I do any differently? Whereas if you say, hold on, that child is being oppositional and defiant because they're having anxiety and they're struggling with their impulse control. So they're actually going into fight mode. Or this is a child who's had to protect their younger siblings because they've been in a neglectful or abusive situation. And so now they view adults as a threat.
No.
Right? Now, how do you look at that child? Now, how do you look at that child's behaviors? Now you look at that child and their behaviors with a much more empathetic lens, and you're going to approach them differently. And your approach is going to help change their behavior. So that's one of the biggest things I think is so important as parents or teachers or adults who take care of kids with any behavioral or neurodevelopmental difficulties or challenges is digging into what's really going on so you can reframe the behavior.
I agree. And I think that's a tough one. And I think when you mentioned about opposition defiance labels, as much as they can be helpful in terms of describing us clinicians to understand what the presenting issue is, but how it's viewed by the actual individual themselves. As you said, that it could be viewed as, oh, you're calling me oppositional defiant. And I think I agree. I think 100%.
Absolutely.
There is always an unmet need that I feel a young person or even an adult who's presented with a certain behavior is displaying is because of something else. You gave a few examples about anxiety, about past trauma, about something else. It's basically a way of them communicating that I'm not happy or I'm feeling a certain way. They just don't, their emotional, way of expressing it isn't the way that society would want. But
they don't have, they don't have the skills or the language to express it in a more positive way, right? And so it comes out in more negative ways, but that doesn't mean that child should be approached in a negative way.
Understand, absolutely. On a lighter note, so you are a podcast host now. You're doing ADHD Essentials with Brendan Mahan.
Yeah. So Brendan invited me on to co-host ADHD Essentials. So I'm not co-hosting every session, but we're trying to do about one a month that I get to pop on and co-host. And we joke that it was really just an excuse for him and I to make sure we scheduled time to get to hang out together. But it's been really fun, and I really appreciated it because I'd kind of been playing around with the idea of doing a podcast for a while, but it's, as you well know, not the easiest thing to do.
No.
And so I was really appreciative that Brendan was like, "Hey, I've got an idea. Let's just bring you onto mine." And I was like, "Cool, let's do that." So yeah, it's been really fun. It's been really fun. We've put a few episodes out so far.
I listened to the one that you did at the conference. I think you were in Brandon's room or something, and there was 20 people in there.
Yes.
And you was just passing the microphone around. That was fun. That was really good. So
that was really fun. I was crying, dude. It was so sweet because he came to me last and I was like, "Why did you do that?" So all these wonderful young people, because it was a room full of the young men's support group and all of these folks. And so I'm listening to all these young people really talking about what the conference meant to them. And then he gets to me and I'm like a blubbering mess. And I'm like, "You realize you're probably going to have to edit this, right?" And he's like, "Yeah, I should have known better." I'm like, "Yeah, you should have." But no, it was really fun though.
That's really good. Is there anything else that you want our listeners to look out for about yourself, or I don't know if they want to reach out to you and stuff as well, like social media?
Yeah, sure. So social media, I call myself a reluctant poster because I am very Gen X. I'm still not totally the social media thing is still a struggle for me, but I'm trying to do it. I'm trying to be better at it. So my Instagram and TikTok tags are at the.adhd.md, and Facebook, I think I have that on Facebook, but also just my name on Facebook because I don't know. Like I said, I'm still figuring it out. But that's one of the main things that I'm working on, and that's as far as contacting me, my office, the email there is probably one of the best ones. That's info@ourplacehealth.org. And yeah, really the social media stuff, and I'm trying to get a YouTube channel started, but in all of my free time.
Yeah.
So we'll see.
We'll see. We mentioned a lot about the child conference, and certainly, obviously, that's, as you said, that's how and where we met, which is great.
Yes.
There's one obviously coming on this year as well. That will be in California, which is obviously exciting and definitely will be there.
Yes.
Are you giving talks this year? Are you giving it all?
Yes.
Yeah.
Yes, I am. So I am going to be on the professionals day this time. I'm doing a medication talk. Probably similar, a little bit similar to the one I did last year, but a little bit more geared towards professionals this time. I am also on the planning committee, like you said. So I'm actually once again throwing the party. So hopefully that'll be a good time, complete with Elton John glasses and feather boas again.
Oh, yeah.
So looking forward to that.
Right.
I may even make sure we've got some Mickey and Minnie ears because we are going to be next to Disneyland. So
Oh,
that might
yeah.
have to be a new addition.
Yeah, thanks for your time. Really excited to, catch up with you as always. And I shall add all your description, like where people can find you on social media and email address and stuff in the podcast description. I know we didn't have time to talk about the shortage of medication, but if you were to say it in one line before we finish, the impact that it's having
Sure.
on people with ADHD, because we're feeling it here in the UK as well.
Yes, yes. So, real quick, kind of the shortage on ADHD medications is actually occurring for fairly basic reason. Supply has gone down and demand has gone up. So the downsides of this are, of course, there were some manufacturing delays for Adderall, and then there were some contract changes with Concerta, and then that trickled down to the other medications, and then of course Vyvanse going generic. We weren't really sure how that was going to affect everything. And I think it's been really challenging across the board. And I know it varies by country exactly how much it's affecting people or with which formulations, because not all formulations are available in all countries. But it definitely has been affecting pretty much everybody. And like I said, the supply went down because of several of those factors. But then the other piece of it is, and this I actually think is a good thing, is demand went up because we're diagnosing and treating people better. And in particular, the fastest growing group is women ages 35 to 55, because we are finally being recognized, we are finally being diagnosed, we are finally being researched. And so that I see as a really wonderful thing. Unfortunately, the supply did not keep up with that demand. And so now we're in this situation that we're in. And it's all I can say about it is there are some tips and tricks on how to try to manage it and navigate it, but nothing's perfect. None of those strategies are ideal. Obviously, the ideal is to be able to get your medicine, your dose when you need it and in an affordable format. That's the ideal. And that's not happening for a lot of people right now. I will say, on a positive note, there's a lot of larger organizations at least here in the US, on the national level, CHAD being one of them, ADA, ACO, all of those, that are advocating for improvement in that situation, and trying to work towards that. So there is work being done. It's just unfortunately things that don't happen as quickly as we need them to happen.
Yeah, yeah. It's been quite disruptive, as you know, with everyone certainly across the board in the world, and it feels like a never-ending cycle that one particular medication goes. It was Vyvanse initially, wasn't it? And the next thing is all the methylphenidate and all the different brands, and we're feeling the consequences of it, particularly with we were discussing about mental health just now there. Certainly the impact that it's having, certainly academically, students, young people, adults, parents, in work.
Oh yeah. It's affecting people's grades. It's affecting people's
Yeah,
jobs. It's affecting people's job security.
yeah,
It's affecting people's mental health for all those reasons. And frankly, for some of us, the ADHD medications, even though they're not antidepressants, because they help get our neurotransmitters where they need to be, help manage our depression. So it's really been tough for a lot of people. And I will tell you, one of the other things that I think all of us can do is, some of this does come back to the stigma and the misconceptions around controlled substances and stimulant medications in particular. And the more we can all work to dispel those myths, dispel those misconceptions, the better chance we have of the supply being less limited.
mm. Yeah.
because that is part of the problem.
And certainly the powers that be will probably pay more attention, because if this was hypertension or heart disease, diabetes medicines, or any of the other sectors of health, surely something would have been done ages ago. But we're talking about ADHD here.
Right.
So, yeah.
Right.
Yeah. I think it's a good way to end. Carolyn, absolute honor having you on the podcast. And yeah, looking forward to catching up in a few months'
Thank you for
time.
having me.
No problems at all.
Yes. I'm looking forward to it.
Yeah, all right.
Awesome.
Take care. See you later. Bye.
Bye.
Bye-bye.